Good morning, everybody. I'm Antonio Mangieri, an interventional cardiologist, consultant in Humanitas Research Hospital located in Milano. And I'm happy to introduce you the results of the COPS, the cutting balloon to optimize stent implantation trial, which was recently presented at the TCT 2022. Okay, this is an important question. It's one of the fundamental points of our study. Calcified lesions are associated with an increased risk of stent failure related essentially to stent under expansion and to a lower minimal stent area when we perform intravascular imaging to assess what was the performance of the stent. And essentially, we have now a number of calcium modification techniques, but unfortunately, we need to customize the treatment for each patient because we have to face a number of patterns of calcification inside of the coronary, so that every time we have to understand what is the appropriate tool for the appropriate patient. Essentially, the cutting balloon is a semi-compliant balloon with 3 or 4 microblades which are mounted on its surface. And the rationale is that the cutting balloon, when inflated at high pressure with a downsizing of 0.5 millimeters compared to the media-to-media diameter, gives us the possibility to distribute the forces of expansion across the blades, so favoring a better cracking of the calcification, especially when we have to face a superficial calcification and not so very challenging calcified scenarios. So our study is designed essentially to address this partially meet clinical need. And so we enrolled the patients essentially with moderate to severe calcified lesion with an arch of calcium of at least 100 degrees. And we compared the performance of the cutting balloon with the non-compliant balloon inflated at high pressures as per clinical practice. Essentially, the study was powered to assess the minimal stent area at the level of calcium site with a NIVUS evaluation performed at the baseline and after the procedure, after the optimization of the stent which has been implanted. Our results were quite good because we achieved the primary endpoint. So in the cutting balloon group, we obtained a larger minimal stent area, and the stent implanted after the use of cutting balloon was essentially more circular, so with a lower eccentricity, which is a predictor of stent failure. Other things that we discovered are that essentially these results are driven by an increase of the minimal stent diameter at the level of calcium site. Unluckily, and as we expected, we had some device failures. So in one case, in the cutting balloon group, we had to perform a rotablation favoring the advancement of the cutting balloon. And in the cutting balloon group, we have two Ellis type 1 perforations. One of them was managed with implantation of a covered stent, and the other one was managed with implantation of a drug-eluting stent. I have to tell you the truth that these two cases were not complicated, so we had no pericardial effusion, the patient was fine and were discharged regularly the day after the procedure. At 1-year follow-up, we also evaluated the rate of major adverse cardiovascular events and the rate of TLR, but as expected with the use of IVUS and with the good implantation of the stents, we had very few events and the trial was not powered to demonstrate a significant difference between these two groups. So the rate of TLR was small and the rate of MACE was even slower. Essentially, the study was limited by the fact that the study was only open label, so the operators know which was the strategy to be performed. And we also utilized a number, of stents with different radial force, which could have been could have a biased result. And moreover, in the database, we did not, finally recorded the number of minutes of procedure, the number of the amount of contrast, the peri-procedural myocardial infarction rate, so that the overall population, the two treatment could have been differently according to the efforts taken by the operator to have a good final result. At the stent, I will say, one of the things that usually are said for the trials is that this trial is quite pragmatic. I mean, it faces a very, daily clinical need. And so, I mean, these results can be easily translated inside of the clinical reality. So when we have patients with calcified lesion and we, do this evaluation with the IVUS, we can even use the cutting balloon downsized, but at high pressure to have a good result and to favor, the good outcome of our patients.